appropriate to initiate the tools. So this is the kind of helpful feedback that's helpful. And of course, positive and negative things are helpful. But ultimately, these activities, these 30-day challenges are trying to support you to have discussions and make changes in the practice. It's not changing the head, it's the hands of how we make change. Okay, we are in session 3. We were focused on identifying people near end of life in session 2, and now we're talking about any tips and tools and hearing from people about identifying people earlier and in the transitional stage. The 2 speakers you're going to hear from are Dr. Samantha Winemaker, Dr. Francis Cobertus. They do not have any financial sponsors or other disclosures to make. And this is the visual, so identify patients at end of life to early transition. We've moved up the step. So this is really focusing on the idea that an early palliative approach is not just about end-of-life care. And if we were to, what would that look like to identify people earlier? And is that going to be more work for us? And how do we actually operationalize it? So this is really what this session is about. Not to those, weeks from death, but maybe months from death. So the reflection question that I'd like to just take, 30 seconds for people to think of is this: what would the benefits be for myself or our team if we could identify people who would benefit from a palliative care approach earlier? So I'm going to give people, 30 seconds or so if you can type some answers in the chat box. Okay. Earlier support, prolonged life extension. Exactly. Perfect. Thank you. I think there is benefits for the patients, but I wanted to just focus a little bit in the next 45 minutes on what's in it for the providers. What's in it for the WIFM is what's in it for me, for you. If you identify people earlier, it's probably, many people say it's less work in the long run because they're moving from crisis mode to a proactive mode and they avoid these crises. The conversation is more gradual. It doesn't feel like so much pressure to make all these decisions. It's a conversation over time. It fits nicely with family medicine because you know these patients, you're seeing them over time, and you can gradually help them across this whole journey. So it's the same work spread over more time, and it helps not just the patient be more prepared, but the clinical team. So this is what we're going to focus on today. So we really asked various speakers, and these are the 2 that the full videos are posted on YouTube. We're going to show the 10-minute clips of what tools or resources or strategies come to mind that people can help identify patients earlier on in the trajectory. So with that, we're going to introduce Dr. Samantha Winemaker will go first, and then she's a palliative care specialist, and Dr. Francis Cobertus, who is a family physician who also does palliative care. And we're going to show their 2 videos back to back, and we're going to have a discussion with Dr. Cobertus joining us live right after. So with that, I'm going to stop my share and allow Kayla to put the videos on.
Hello, I'm Dr. Samantha Winemaker. I'm a palliative care physician working in the greater Hamilton area. I work mostly in people's homes, but I've also had experience caring for people in hospice and acute care as well.
I've been asked to speak to you today about early identification. How do you know whether a person is in the early versus transitional versus end-of-life stage of their illness? One stage blends into the next with no well-defined point in time. Like the colors of a rainbow, it's hard to tell when one color ends and the next begins. Why does this matter? Because in the busyness of acute and episodic care, we can easily miss the big picture of the illness until a person is very late in their journey. I suspect that after the last module, you were readily able to identify people in your practice that were in the later stages of their illness. Dr. Marshall shared with you some tools to help you identify those patients who are likely entering into the last year of life. Some illnesses carry with them an average life expectancy of 2 to 15 years. We don't want to miss the opportunity to start integrating a palliative approach more upstream than in their last year. You may recall from the last module these general illness trajectories. Broadly speaking, there are 3. There's one for cancer, one for end organ illness like heart disease and lung disease, and one that depicts frailty and dementia. It's more obvious when people have entered the late transition phase and end-of-life phase because the tipping point, the physical decline, can't be denied. In the transition stage and end-of-life stage, function is clearly declining. The PPS, Palliative Performance Scale, is a helpful scale to track these functional changes and help identify which stage a person is at. The green represents early, the yellow, transition, and the red is end-of-life. By the time a person has entered a PPS of 60% or lower, what I refer to as the tipping point, months and years have gone by, and the risk is that we've missed important opportunities to begin peppering in a palliative approach earlier. As a palliative care specialist, I tend to meet people very late in their illness. However, I had a unique vantage point during the first 10 years of my career. I was fortunate to work embedded as a palliative care specialist in 2 very large primary care practices. I was able to observe how different primary care clinicians care for their patients with progressive life-limiting illness. It was clear to me that some were doing it very naturally as part of their usual practice, utilizing my skill as a specialist only as needed. We sought to understand this in more detail, so a group of us from McMaster University interviewed clinicians who were identified by us as exemplars and asked them how they cared for these patients in their practice. By the end of the research, I had gained new insight into how these primary care clinicians operate upstream in the illness in the earliest stages. Broadly speaking, they described 4 different themes. The first is focused on the patient's diagnosis. The second is a change in their needs. The third, functional decline, and the fourth, heightened acuity. I'll now go into these in more detail. These primary care clinicians knew from the get-go of the diagnosis of a progressive life-limiting illness, such as congestive heart failure, COPD, interstitial lung disease, cirrhosis, ALS, Parkinson's disease, dementia, frailty, etc., that these illnesses had a natural history of decline over time. They readily identified when their patients were diagnosed with these illnesses that they were going to require a certain type of care along the illness journey. They also picked up a change in the patient's needs. They would tap into changes related to the patient practice routine and the visit pattern changes. They described increasing family involvement in patient care was often a cue that something was changing, or that specialists were becoming a part of the care team. So something was changing with respect to the needs of the patient and family. Examples included increased phone calls coming from the patient or their family, missed appointments, needing longer appointments, suddenly coming to the clinic with a friend or family member, needing home care or other resources. And most interestingly, many of them just described an experience of a gut feeling that something was different with their patient, that their needs were changing, came from their gestalt feeling of the patient. They also picked up on functional decline, that over time they noticed early changes, that the patient was potentially going downhill in some way. This could be slow or sudden, that their physical and mental psychosocial well-being was changing. They were more tired, maybe looked a little more weak, had had some early weight loss. The patient was beginning to perhaps have trouble looking after themselves or started needing assisted devices. Perhaps they were less socially engaged or feeling depressed or anxious. Again, cues they described to pick up on the changing nature of their patients. Lastly, they tapped into a sense of heightened acuity, that there were things about the interactions between the patient and the practice that were different, often emerging from crisis-like incidents. There was an increased sense of urgency. There were more exacerbations of the illness and perhaps coming closer together. A hospital visit, an admission or ER encounter. That there were increased needs of the specialist or abrupt need for a family to be always with them or home care to be involved. To be successful with earlier identification, they relied on their knowledge of which illnesses inherently have a progressive life-limiting nature right from the time of diagnosis. They did not wait until there was a tipping point and a very obvious functional decline to begin to shift the type of care that they were providing for the patient. They used the illness trajectories in a more natural way just by understanding the natural history of certain illnesses. It's still helpful to use the prognostic indicator guide or the supportive and palliative care indicator tools or the PPS, as have been mentioned in the last module and this module. But at the end of the day, these primary care clinicians use their good clinical acumen, their knowledge and relationship with their patients over time. And this qualitative study that I have described to you helped us understand the natural ebb and flow of primary care practices upstream in the care journey. These clinicians used the relational aspect of primary care and longitudinal knowledge of their patient. They relied on their spidey sense, their gut feeling, to notice change. It wasn't just the nurses and doctors. They described frontline staff reporting noticing change. Often frontline staff have an intimate and longitudinal relationship with patients and families and can pick up on change even before other clinicians in the office. I encourage you to develop a list of red flags that may alert the practice that a person has a progressive illness and that there is change that is happening. Perhaps you will add to your roster that you made after the last module. You may decide to use electronic flags or your team huddle to discuss some of the concepts that have been reviewed in this module. Acknowledging the role of the caregiver, who may or may not be a patient in the office as well, and inviting him or her to be involved in the care intentionally will ensure that you receive intel from this informal care team that surrounds the patient and can help the practice pick up on things changing without relying only on visits with the patient, him or herself. The take-home messages are quite simple from this module focused on earlier identification. Number one, identifying patients earlier is more natural than having to wait until the very end. It's less about the science and more about your instinct. Leverage and trust your collective knowledge of your patients to pick up on change. Thank you.
Hello, my name is Frances Kilbertus and I'm a family physician. I'm a family physician and I practice palliative care. Palliative care has always been part of my clinical practice and my teaching practice. I have practiced in a large urban center, in a downtown community health center, in an academic teaching unit, in a tertiary care hospital, and now I work in a small rural community on Manitoulin Island. I work in a family health team, I work in a hospital, and we provide full full coverage primary care from a generalist perspective. It's a really interesting practice, and it's been a really interesting transition to see how my palliative care work, both teaching and clinical, has been influenced by the context of my practice. I'm very happy to be here and to share this perspective with you. Today, I'm going to address a few questions regarding identifying patients at an earlier stage in their disease or diseases trajectory. We're going to look at some of the barriers to using standardized tools to identify patients who would benefit from an earlier palliative care approach. We're also going to look at barriers to monitoring patients as they transition from one phase of their illness to another, and some of the strategies or tips that might be used to overcome some of these challenges. So in session 2, we talked about tasks and doing something small and manageable that really would let you dig into the whole practice of looking at patients who would benefit from a palliative approach, initially more towards the end of life and now further upstream. So from that session and the task associated with, have you looked into your own practice and identified someone who has the responsibility for the so-called list or registry? Has that been effective for you? Have you been able to capitalize on people's interest and passion for doing this kind of work? How have you been communicating this work within your practice with patients and families? Is this working? For example, is your appointment time long enough? Is this generating a whole lot of after-hours business that you didn't anticipate? How can you manage strategies to deal with that? So the first thing I'd like to do is underline the palliative performance tool as a really helpful tool to identify these patients in your practice and to use this tool as communicating with others. I have a little story about my practice here in Mindamoya, and it is a practice that is in the clinic and in the hospital. PPS was an unknown term in our hospital, I would say, about 5 or 6 years ago. We deal with patients with multiple comorbidities, and as you know, as family health teams, most of our patients have multiple illnesses and will likely die from their multiple comorbidities. Our small rural hospital is full of patients with multiple comorbidities who are at a palliative performance scale of 60% or less. Through integrating this one tool in our common language that we share when we discuss patients among our healthcare team, we have shifted the way we are looking at patients who come into our hospital with multiple comorbidities and are declining. I'm proud to say we've stopped saying a patient is palliative, which to me doesn't really make a lot of sense. But we're talking about a palliative approach, and we are talking about the quick way of communicating where a patient is at in their disease trajectory by using the palliative performance scale. When a colleague says to me, we've just admitted a patient who's PPS of 40, but on their last admission a month ago, they were PPS of 60, we trigger a lot of common ways of thinking, and I think that's been a real success. We are also using that in our family health team. The strength of primary care is the relationship with the patient. We are the experts in the relationship with our patients and with their families. And this relationship really enables what I will call clinical acumen in recognizing when people are declining. And this might be quite a bit upstream. This might be in the instance of a lot of chronic illnesses or chronic comorbid illnesses. This might be a year or more from their actual end-of-life situation. But it really helps us to identify that this patient is declining in a way that may require identification of current needs, strategies to look at unmet needs, and most of all, anticipation of care needs. So I'm going to ask you, what do you need to do in your care team to develop a common language, both internally and externally with your care partners in the community? I'm going to suggest a strategy that focuses on the PPS. There are ways to document and chart the PPS in your clinic EMR. Just as with weight or height or blood pressure, these numbers can be graphed over time. You can look not only at the current PPS, but at PPS over time, at least in my EMR, through the click of a mouse. This really helps you to align what you see in a person in front of you on that day with their disease trajectory. We've all seen the trajectories of cancer, non-cancer, and dementia as outlined in previous slide, and you've probably seen this in many places. But actually enumerating the PPS and watching it change over time can be really helpful and in triggering conversations among your team and communicating with your care partners in the community. Sometimes it's rather surprising when you've seen someone recover many, many times from their multiple exacerbations of their many healthcare challenges to looking at the big picture, that they've actually gone from a PPS of 70, which is really being up and about and quite engaged in life, to a PPS of 40, which is really carrying the burden of their illness quite a bit more heavily in their home and in their community. So my take-home messages today are, first and foremost, take time to reflect on how this process has worked so far. What's been good, what's been bad, what's been really challenging on an individual, on an interpersonal, and on a systemic level. Look really carefully at your structural and systemic challenges, because you have to create the changes that will work in your environment, and they may not look like the changes that will work in other environments. Your strategies may be quite unique. And finally, maintain that team conversation on the impact of how this care is affecting how you see yourselves, how you see the work you do as a family health team. I also think this team conversation really does move out into the bigger community of other caregivers, and it reflects the fact that palliative care is part of primary care. We do this work. We have always done this work. Systems have changed, and that has impacted how we do this work. But this work is very much part of being a primary care team.
Okay. So those were the two videos of with Dr. Winemaker and Dr. Kilbertis. I put on Dr. Kilbertis is joining us from Manitoulin Island. I'm thinking, nope. Your sound is on, Francis. You can join us.
Oh,
so
okay. I thought I was muted. Sorry.
Yeah, no worries. So this is an opportunity for the people on the webinar to reflect on what they just heard from Sammy and Francis. And I think, the chat box is there, so Maggie can moderate that, or people can just pop their questions, unmute themselves. But really what we're thinking about is, were there any light bulb moments that help you to think about, what are the benefits of doing it earlier, things that I could actually implement, or are there questions that you have? So I'll let people take a moment there to think about that.
So Francis, we had a question about what EMR are you using?
We use the TELUS EMR Practice Solutions. Are you familiar with it?
So I'll let Richard unmute and then he can talk directly to you.
Okay.
And in the meantime, as that's yep.
Okay, yeah, so custom form then, Dr. Gilbert?
It's, do you know if you want to follow someone's BP, you do control BP, and then you can get the graph of the BP. You can graph it that way using.
Okay, but yeah,
you have to enter it. So you have to enter it. So if you just want to follow the score, you need to enter it in a standardized way, PPS : number.
Okay, so not using a stamp or a form?
Correct. There is a group in Sudbury called City of Lakes Family Health Team, and they've actually done the stamps. So there are available. We've got slowed down a little bit by some internal problems about getting them actually into our EMR, but they have a whole suite of custom stamps.
Okay.
So that you actually don't just see the number, you see the answer the questions. Also ESAS and some others. And I can follow that up for you.
Okay. Yeah. Thank you.
Yeah, and I'm not a Manitoulan. I'm in BC. Holidays.
Mhm.
So that's where I usually live, though, Manitoulin.
Thanks, Francis. So we have another question about if you have a good coordinated care plan template for PS suites.
I'm assuming that this is a coordinated care plan with respect to patients who are palliative. No, we don't. And I think again, this might be something that you have to consider in the context of your practice. The variety in my current practice, and if I think back to the urban practice as well, there's so many particulars and contextual factors, and in my current practice, multiple comorbidities, that it would be hard to follow a care path per se. What actually I think would work a little bit better, and I might take this back to my practices, is to just, what are the tasks that need to be addressed when you're identifying someone early in their illness trajectory? So if I'm thinking, let's say, and this is very common in my practice, perhaps yours too, someone with COPD and CHF and elderly is declining. You know, they were really at a PPS of 70, now they're 50, it's not too bad. What am I going to do differently in the moment? Probably nothing dramatic. I'm not I'm not moving them off the CHF algorithm or the COPD standard approaches, but I want to make sure that I'm really addressing symptoms well, that I have myself or someone on our team has a better understanding of how they're coping at home in our circumstance. There's travel, there's driving, there's bad weather. What are the perhaps anticipated needs for that person? So I don't know if that's what you mean by care pathway, but I could see a trick. I'm talking about PSS, EMR. You could, once a PPS hits a certain number, if you're tracking it, then the reminder gets triggered. We will leave the discussion about, how many reminders get ignored, but, theoretically, there is a frame to do it.
And Francis, as a follow-up to that, I think it's really key what you said about, because even though they are declining, but there's nothing clinically you change, it doesn't mean you don't do anything. So what are some of the things, that you put them on the registry, maybe you're tracking them, but what are some of the things that go through your mind before you would say, okay, like what are the conversations you have? What are the things you start to think about differently in your mind, even if they're still on the, the CHF pathway?
Mm-hmm. That's actually, I think that's a very good question. When I was thinking about this, actually, I listened to both mine and Sammy's presentation so I could get into the mindset yesterday. And I think there's a piece here about what are you doing as an individual practitioner? So the kind of conversations that I would have is, number one, okay, if we want to start with the biomedical, I look at the drug list. Are all the drugs appropriate? Is the list up to date? Very practical things in the primary care. I might just look at, I don't know how folks who are using EMRs put in their documents, but I might just scan through the last 2 or 3 discharge summaries if they're available. In my community, because I've been there, I'm a migrant, so people who've been there a long time really know people well. I'll ask a secretary or a nurse, what do you think, how does the patient look like? Anyhow, back to, but you just want to make sure they're on the appropriate treatment for their underlying diseases and their symptoms, and that those are not working in cross purposes. You have to ask them about advanced care planning. We kind of take pride that we're really moving ahead in our small community about having these conversations, but we're in a culture that really does not talk about that much. So we did an interesting little project of looking at, and if you're in PSS, you just do a search for everybody over 90, and how many of those people have actually advanced care planning in their clinic chart in a way that you can see it. So I'm not going to go through reams and reams of office visits and search words and stuff. I just want to see it right there in the profile. And we were quite scandalized about how few there were. So I want to have that conversation. I want to know who will speak for them if they can't speak for themselves. So I changed my approach from treating the illness to really, it is a more global caring for the patient. And if I could, it reminds me of one brief story about that in a more acute care setting. So as a rural practice, we also do care for our same group of patients in hospital and emerge, which somewhat makes it easier. And someone, is brought in by ambulance in extremis, some kind of very life-threatening problem, and they come in by themselves and there's no information, and, the adrenaline levels up, everything, the IVs and bags of fluid and etc. are all going, and people are like, they're pumped, they're working, this is like adrenaline stuff. And then a family member comes in and says, this is not what my family member wants. And I'm proud to say that we can turn our resus room into a hospice suite if required. And what that does, it just settles everyone. It's like having permission to care in a more holistic way than focus on the illness and disease and saving, salvaging or whatever you want to call it.
Do you think we have time for one more question, or should we move on?
The follow-up, I think, is okay. Go ahead.
Yeah. So Francis, just in follow-up to that, is the tipping point for you more to address symptoms than anything else?
I think I would say it's equal address symptoms, and particularly in CHF, like that's just a little bugaboo of mine. Your blood pressure has to be high enough for you to stand up without being dizzy. Addressing symptoms and not just disease indicators. And number 2, planning, equal footing. Like, I don't know where I'm going unless they can tell me in terms of how we're going to march through the next inevitable part of the journey.
Perfect. Thank you, Francis. Okay, if you're able to, I hope you stay on, because what we're going to do now is transition to the 30-day challenge, which is building on the activity that you did in session 2, which was starting to think about a way to, quote unquote, create a registry or a report or a list of patients who are at end of life. And now we want you to start thinking of what that would look like. How would you modify, adapt that, or build on that if you're talking about identifying people at a transitional stage? And so the questions that we're going to give you about 15 minutes to think about, or 10 to 15 minutes to think about on your own or as a team, whose role will it be to flag these patients? How would you do that? How can you adapt what you did before to include these additional patients? And what will you do differently with these patients? Whether it's, concretely doing a medication reconciliation, or, thinking of, I need to have these conversations, or how are we going to do that planning piece? So the 30-day challenge is to use this time, about 15 minutes, to talk or to think about some of the answers to these questions, so that if you're not in the same place, when you do meet, you can do that. If we're still online, so if you get stuck, please type in your questions on the chat, and we'll answer that, and we will check back in maybe 10 to 15 minutes or so to see how people are doing. And I'll go back to this stage so you can see some of the questions we want you to think about. Is that clear? I'm going to mute myself, but type in the box if you have questions. Thank you. Star. So we're gonna probably 2-minute warning. Maybe we'll bring it back to discussion in about 2 minutes. Okay, I'm going to try and bring people back into a discussion. I'll bring Francis back online. And just check in with how people are doing. I know it's hard because some people are not with their teams, so it's more self-reflection. So that's why we're trying to break into a discussion a bit earlier. But maybe I can start, and people can feel free to unmute. You can either type in the chat box or unmute yourself and ask your question directly. So please feel free to do that as well. I guess I wanted to start maybe while we're waiting for people to put in questions or unmute themselves. Francis, from your experience, when doing this work about the registry and finding people at end of life who are sort of you'd be very concerned about this week, compared to this idea of flagging people who are in their transitional stage, was that the same sort of practice? Is it the same kind of thinking in your, not the mindset of the provider, but what does the team need to do in their office practices to, is there a big difference or is it very similar?
I would say the difference is the urgent nature of someone declining and declining rapidly at end of life. And that's the oftentimes unanticipated mad scramble to get services together and connect people. And so it's the end of that trajectory, but everything, it's like the stage 2 labor, it all gets a little bit more dramatic at the end. And sometimes more difficult and sometimes not, sometimes it's actually very peaceful and you just have to understand that you need to be there a little bit more often or get other people in. The longer trajectory is, of course, the more difficult one, which is why I probably say, trying to define a patient registry around that in the next 30 days would be an impossible task. And we do want to set up things that we can actually achieve in 30 days. I would say just looking at your own practice and trying to identify a couple of people that might be, say, between PPS of 70 and 60 and 40. And maybe if you don't see them, have a think about what's missing in them if they start to decline now. What hasn't been dealt with, whether it's biomedical questions, services, psychosocial care.
Excellent. Okay, I'm going to give people a moment to pose some questions on their own. Have you noticed differences? But how different is it if you're in an urban setting versus a rural setting? I know you've worked in both, and in smaller communities versus more urban cities.
So this is a huge area, and I want to not frame it in the usual rurality as a deficient state, actually. So what's really, really strong in rural settings is you are known, I am known, and to the community, and people in the community know each other. And so as a care provider, I am part of the community. I am not apart from the community and taking care of people I don't bump into in other areas. And this actually can be quite a huge strength. And I'll just do this little, if anybody's working rurally, there's a wonderful book called Rethinking Rural Health Ethics. It's brilliant. And what it talks about is that whole notion of, you do have entwined relationships. It's not necessarily a bad thing. So the downside of doing this work where I work now is we basically, this is a private conversation, have a home care that does not function to care for people dying in their homes. One daytime available nurse over a big geographic area doesn't, it's just impossible to provide the models that you see reported as being the best care, like interprofessional team, home care, shift nursing. We have none of that. So it's amazing how people get creative and adapt to the context, or they come into the hospital and that's where they die, either in the hospice suite or in a hospital room wherein we are providing hospice palliative care as an approach to care, not as a place. So I think in the city, there's a lot more resources, and that's great. You know, you can call on a team, you can get nurses, shift nurses, you can get equipment out quickly. Your pharmacy isn't 2.5 hours away, I hope. But the downside is actually you don't really know the patients and families quite as well, unless you've been their long-standing provider. That's a brief overview of some of the differences.
Thanks, Frances. Are you able to talk about if advanced care directives should be addressed prior to this stage?
If I have one job left in me to the end of my career, is that this becomes a common conversation that people are willing to talk about when they are, I don't know, young, getting married, having major life events, having kids, seeing their parents die, that we talk about advanced care planning as a normal thing, not a extraordinary thing and a harbinger of the end of life. So a lot of my conversations around this are prefaced by, this is something I discuss with everyone. Like, I learned when I was earlier in my career to ask everyone about, you know, bowel movements and sexual health. I present this as part of the conversations, and I know lots of practitioners who've incorporated this into their periodic health exam at a certain age, like 45, because once the conversation is started and is not threatening, it's just easier to pick it up, and people are already thinking about it. And my worst nightmares are people coming in dying into an emergency room, and I have no idea, and nobody has any idea what they want.
Thanks, Frances. I'm going to go up to a question that we didn't get a chance to address earlier about when you were mentioning creating a reminder in the EMR for patients as at a predetermined PPS trigger. What does this reminder look like? So can you speak a little bit to that? Like, how might it be worded or something like that?
So I think it's a pretty straight, like, my view of reminders is they just need to be brief and you have to look at them. So for example, when someone's tetanus is out of date, we say needs an Adacel. So PPS 50, PPS 50 conversations ? Because that's only, you see that on your screen. Or if you have a template, like if you make, this would be beautiful, and maybe we'll do it. Just a stamp, custom stamp that says, you know, that has the tick boxes about different conversations, review medications, find out about home life. Are they connected with home care? Is there advanced care planning? What is patients' wishes? What does quality of life look for them? Like, if you have you can just say PPS 50, consider custom stamp or something like that.
Thanks, Frances. So I know we're going to get into a little bit more of the conversation piece on session 4, but a question has come up about how you fit advanced care planning into a visit with your patient. Is there a specific resource that you like to use?
I guess I am an on-the-fly person, so I don't have a standard conversation. I've developed, and the more you do this, the more it becomes part of your natural parlance in a conversation. I start with chunks. So if I'm, you know, we've got short visits. That's why I think you have to really think about what you're going to do in your context. I might just start very easily about, I ask this question to everyone. I don't see on your chart who will speak for you if you can't speak for yourself. And that might be the only question I ask. But it's usually quickly followed by, would they know what to say if you couldn't express yourself? And that might be all we're going to get into today. I have unfortunately heard through other channels, you know, there's family physicians who just say, I will never have these conversations. They take too long. You can break it up. It's really, you're introducing concepts to eventually have a fuller discussion, which is why it's really good to have them when patients are well or when they're earlier. Because if you don't, they're going to end up somewhere, possibly in the emergency room where I am working with them. And either I have to have this conversation when someone's life is ending, which is a horrible time, or things are going to happen that they didn't want to happen. I think we've got a good Canadian study of a few years back showing all of the stuff we do to patients at end of life, which they expressly did not want.
Yeah.
And they framed it as medical error.
Yeah. So I'll just say that it's really important to underscore here that in session 2, where we're looking at a registry for people at end of life, and session 3 is transitional stages, the emphasis is not on what you're going to say to your patient. There's a whole session, module 4 is all about the conversation skills and strategies and tactics of what to say. There's a beautiful framework. You can read ahead and start thinking about that now. This whole is behind the scenes of what is it in your mind that you need to do when you see these flags triggers. Do we have a process in place? Who's going to do it? And what do I need to think about? And so that's kind of what we're trying to, and this one is about transitional, the previous one was end of life. So I know a lot of the questions are what do I say and advanced care planning, that I promise you is covered really nicely in session 4. And onwards, but this is really about the practices of what we need to do to make this happen. There's a couple more questions, Maggie, and then we can, and Francis.
Can I I see actually I see the question with the question. So now just to then I break down the discussion. The Pallium website with the advanced care planning is where I refer everybody to and encourage them to read it before they come back. And often we have identified 2 people in our practice, one nurse, one social worker, who, if they want to have an early follow-up, if they want to have a follow-up discussion, we book them with them. So they've honed their skills.
Thanks, Francis. Okay, so we have 2 questions. I think we can get to both of them. So the first one is the PPS not only validated for cancer patients?
It is a tool for cancer patients, yes. It does, and it's not a prognostic indicator either, though there's some work around that. What it does in my mind is it just changes your way of seeing the patient, not as someone who's, disease we're fighting, is that while we're doing that, there is a decline. So it's not validated in terms of non-cancer. I don't think Cian can answer
it is,
that as well.
It is validated in non-cancer patients. And again, it's, yeah.
Okay.
Yes.
Oh, well, it is.
Well, do you use it for non-cancer patients? I mean, how would you? Yeah, there you go. So that's the answer to that question.
We just nurse says PPS 20. I go, okay, I know what you're talking about.
Okay, thanks. So the Perry Sound Family Health Team is wondering what you see the role or tasks of a person who maintains the registry.
I think that first and foremost, it's about ensuring that there's a connection to the practice. So, Perry Sound is in our district, and I don't know how spread out your population is, but you just want to make sure that maybe someone is connecting with them under a certain PPS, that perhaps someone is checking in with them from time to time. I think you can, and certainly in urban areas, you lose track of these patients who are getting more and more ill quite quickly as they kind of funnel out to the specialist care world. So maintaining a relationship and a connection to the practice, a regular check-in that you can determine whether, related to PPS or just, as clinicians and staff see fit, that you actually connect with them. You say hello, you say, just wondering how you are. There's been, in my urban practice, that was a huge tool. When people did kind of go off, I just called them, or the team nurse called them, or the secretary, and just said, are you just doing okay? We're just checking in. And I found that a really good tool.
Okay, let's, thank you, Francis. I think there's a rich discussion. And so I want to bring us to our, just close out the next steps. So a reminder that you should email your team lead right away to let them know you attended, so that we know we can send out participation certificates and keep it track for people who are applying for CME credits. So we don't check the chat box. We ask the team leads who joined. You will also receive the webinar evaluation, 5 quick questions of which everyone will get, and it really helps us to make these better and better. Over the next 30 days, think about the things that you're going to do to identify people at the transitional stage. What kinds of things you're going to think about? How do we flag them as a practice? What are we going to do? We're going to worry about what we say to those patients in the next module. This is just behind the scenes. Who's going to do what? Who keeps track of them? What are their roles? As you have those discussions, any questions that you have, email your Kayla, Maggie, or Daryl, your team facilitator, because we ask a network of people across the country to answer those questions, and we get back to you by email. And of course, there's additional resources in the appendix. A lot of the ones about advanced care planning are in the next session. You can look at those. They're all online, palliativecareinnovation.com. And then at the end of the month, please send your monthly team reflection. The team leads to hopefully get in touch with you to fill that out. And then there's a draw. So today, session 3, you have until the end of today, 5 o'clock, to submit your stuff to your team leads, and we will draw tomorrow, and then we announce the winner by email to everyone. And it's $100 to, for coffee or a lunch for one of these meetings and things like that.
So, and just to clarify, they have till the end of the day to send a session 2 reflection form, not session 3. You have more time for that.
Thank you. And with that, we have perfect on time. Thank you very much. Please keep in touch by email and talk with your facilitators. And we look forward to seeing how you're doing and see you at session 4. Bye, everyone. Okay, we can still take chat. I should have said we'll stay time. You don't need a program per se to identify patients who would benefit.